You're tuned into Recovery TV, the voice of hope, with your host, John J. Tassoni Jr. Discussions and information on addiction and mental health issues. Here's your host with today's guest.
Welcome to another edition of Recovery TV, and I'm your host, John Tassoni. Narcan, please get it. It's saving lives. The overdose deaths are down because of Narcan. You can get it at CVS, you can get it at Walgreens, you can get it at URI. Put it in your car, put it in your pocketbook, take it out at night because it's affected by the weather. My guest today needs no introduction. AG, Mr. Peter Neronha. Welcome, General, and thank you for joining us
Senator,
today.
good to see you.
I want to talk a little bit about all these lawsuits that are happening with the opioid crisis.
Yeah.
How much money's coming into Rhode Island, and are we spending it in the right places?
Yeah.
So the floor is yours.
Yeah, so I'll try to take that question in each of its component parts. So the amount of money that the office has brought in exceeds $300 million in settlements with manufacturers, distributors, pharmacies, including CVS, Walgreens and others, Purdue Pharma, of course, one of the biggest players in the opioid crisis, if not the biggest. And so that money under the settlement agreements that the office signed with all of those companies, and they didn't all happen at the same time. It's a lot of work in each part, but I'll put them all together.
Right.
And we're around, I think, $350 million when you put it all together. That's coming in over time, which I think is a good thing. It's sustained programs rather than spend all the money. You feel like you have to spend it all at once in one place. You don't spend it well. But they're, by virtue of the settlement agreements themselves, there was a committee that was set up, which has constituents from each one of the counties, has a member from the public health community, the Senate, the House, my office. It's chaired by the governor. And what that committee does is it advises EOHHS on what the governor should put in his budget to fight the opioid crisis. And do I think it's being spent well? The broad answer to that is yes. There's been a lot of money spent on brick and mortar, and that's a good thing. We've added at least 51 more beds, which is important. Not having enough residential treatment, which some people need, as you know, Senator, is you've got to have enough capacity there. I think one of the things that I would like to see improve is spending more money on outpatient treatment, because that's where most people go. Not everybody needs residential. But I would say yes, I think the money is being well spent. I think the proof is in the pudding, if you will. Opioid overdoses are down 25% over the last several years. So at times it can be a cumbersome process, but I do think it's working. And I think, again, we're seeing it in the numbers of overdoses declining for the first time in a very long time. As you know, from about 2013 on, they were going up dramatically every year, and they've come down some.
Right. What's your thought about doing something with Memorial Hospital as far as a place where we can do residential outpatient treatment?
Well, I think if that facility is capable of doing it, my understanding is that since it closed, it has not been kept up very well. It's gone through a number of owners, not all of them able to pull off what they claim they could do there, and that's in litigation right now. If that facility was in the state of the art, safe, clean, secure, meaning the roof wasn't leaking and all that kind of thing, sure. But I don't know whether it's capable of doing that. But I do think there is opportunity as we begin to potentially reimagine how Roger Williams and Fatima hospitals are being used potentially in the next 6 to 18 months. There may be an opportunity to add residential treatment there. As you know, there's a lot of behavioral health beds at Fatima, 80 to 90, I believe.
Right.
And without those behavioral health beds, the state would be in real trouble. So there's already some, there are already some services there that are, I would say, in the same healthcare bucket as residential treatment, and that might be a natural place to put some more beds.
Yeah, as to the issue of Butler Hospital now putting a wing up for mental health stuff. there are people around the state are looking at Fatima and Roger Williams. If in fact they stay open,
Yeah, that's critical first step.
It's a $64 question.
Yes. Yeah.
If they close, we're in serious trouble.
We are. You know, one of the things that we've talked about collectively, the House, the Senate, the governor's office, including the governor, we just actually had a meeting today, is we recognize the importance of those hospitals. We also know that public support is probably going to be necessary to keep them open. It's not enough just to say we're in trouble, we have to keep them open. Mm-hmm. It's going to require money. Massachusetts spent $600 million to keep open the hospitals that were in a similar position after Stewart ran them into the ground. Here, Prospect ran these hospitals into the ground. So it's going to take some public money, I think, to do it. But it's an opportunity. It's an opportunity not only to make those hospitals stronger, but to the extent they need to be reimagined, re-envisioned, if you know what I mean.
Right.
Make them more efficient for today's healthcare climate.
Right.
Keep certain services, perhaps change others. And I have no plan in mind, but it may be an opportunity to have them come out stronger with public support so that they continue to be strong community assets. The workers are phenomenal.
Right.
But there's certainly a tens of millions, if not hundreds of millions of dollars of capital investment that needs to happen. And finding that solely in the private sector for these hospitals, I think is going to be difficult. So it's going to require some public commitment.
You know, I've been talking to the speaker about possibly doing something with the HHP that they have in East Providence. These small places that are 23-hour-a-day facilities, and putting 3 more. So we have 1 in each corner of the state. Because if in fact Roger Williams and Fatima close, there's not a lot of places that these folks can go to.
Yeah, it's true.
You know, I was just in Rhode Island Hospital. I think the wait was 12 hours. And that's with a full complement of hospitals.
Yeah.
Now, if we lose 2, that 12 is going to go to 24, 48, 72 hours.
Yeah.
I was just speaking to my neighbor who was in Fatima. She was in 2 days in the emergency room, just sitting there waiting for a bed.
Yeah.
I mean, we got a huge problem with,
Well, that's,
the flu.
Yeah.
But that's, a story for
Brown
another day.
will tell you, I met with some ER doctors about a year ago, we were talking about what will it take for us as Rhode Islanders to understand we need to do something different than what we're doing for our healthcare system. And I said, well, look, it's going to take, I think, spectacular failure before you can get someone's attention. It's very difficult. You serve in the General Assembly. There's a lot of people pulling at senators and representatives. Someone's got to take the bull by the horns and drive it, right? If you don't drive a solution, solutions aren't just going to happen. And what I told those ER doctors was, it's going to take spectacular failure, something like a hospital closing, for people to wake up and say, hey, we've got a problem here. And they told me, we're already in a state of spectacular failure because they're boarding, is what they call when they're leaving somebody in the ER who needs a bed on the wards, in the the upstairs usually, where the beds are, ICU or otherwise. They're leaving people in the ER, 50 people a day throughout the Brown system. That is the normal.
Right.
That there are 50 people at any given time waiting for a bed that need one but can't get one in the Brown system. Right. And that's, I would argue, that's the system that is most economically strong at the moment, and they're facing that problem. It's not something they want. It's something they aren't unable to fix.
We have to go to break, and when I come back, I'm going to make a statement. It's not popular, but it's truthful.
Okay.
You're watching Recovery TV, and I'm your host, John Tassoni. We'll be right back after these messages.
And now back to Recovery TV with your host, John J. Tassoni Jr. Recovery TV is made possible by our supporting sponsors and our title sponsor, Kodak. Now, here's John and today's guest.
Welcome back to Recovery TV, and I'm your host, John Tassoni. The AG is in the house today, Mr. Peter Neronha. Thank you, AG. I know you're very busy. It's been a very busy couple of months for you, I know. So thank you for joining us today. So the statement I want to make is the healthcare system in Rhode Island is broken, and is broken badly. As you indicated prior to this conversation, we need to get everybody in the room, we need to fix it. How do we fix it? I'm not sure how to fix it. I'm not a medical guy.
Yeah.
I just put people in treatment.
Yeah.
But even that area of treatment, we have alcohol now as surpassing the opioid crisis. How do we fix that?
Yeah.
You
So
know what I mean?
let's start with the healthcare system. So I believe that a lot of it is financial, that the way we are investing in our healthcare system won't work for the long run. We have to get our so the only way providers of healthcare, doctors, hospital systems get paid is either by Medicaid, which is for economically disadvantaged Rhode Islanders, Medicare, which is for older Rhode Islanders, where I'll soon be in just a couple of years, and then commercial insurance, Blue Cross that you buy on United, that you buy on your own, or that you get through your employer. And so those are the only ways that providers get paid. And for each bucket, we get paid less than our neighboring states, so that's less money coming into the system, which means less investment in both the personnel side and the capital side, meaning buildings, machines, availability of tests. And so a lot of it is revenue. I think a lot of it too is that we are not leveraging our state dollars. So when we invest state dollars, say in Medicaid, we get a federal match. We have not done as good a job as some other states in doing that. It's not about the people in the Medicaid office. It's about building a Medicaid office that actually has the ability to do that. And so we think part of the solution is really twofold. One is we have a lot of state agencies doing healthcare, but they're not really connected. So you've got the Medicaid office, which is an EOHHS. You've got the Department of Health, which is also an EOHHS, but not combined with the Medicaid office. You have the Health Insurance Commissioner, which is its own thing. We feel like putting the components together and adding a strategic and data-driven part of it, like it happens in Massachusetts, can help us come up with solutions for the General Assembly and the governor, to drive healthcare forward. But somebody's got to own it. It requires the data, and it requires somebody to care enough about healthcare and leadership to own it and drive it. It's doable, but it's also hard. And I think when there are issues that are hard, and sometimes hard to understand, it's a natural human inclination to not focus your time there. But I think that's where leaders have to focus. And that's why I've spent as much time as I have on healthcare. I didn't come into office thinking I would spend as much time on healthcare as I have, but we built a really strong team at the office which can not only regulate individual healthcare transactions, mergers and that kind of thing, but also can drive policy solutions. And so we're putting in legislation to build that very kind of agency.
Good.
To come up with also legislation that would create what we call a public payer option, meaning a health insurer that's run by the public. We think we can do it and provide competition to commercial insurance to try to drive their rates up. We think there are ways to invest in primary care. So here's an example. The governor's budget has $200,000 in it for loan forgiveness for primary care doctors in Massachusetts.
Where are you going to go with that?
In Massachusetts, the number is $25 million.
Right.
So whether you're I just met with the federally funded health centers, like Blackstone Valley Community Health, for example. I just met with them this week. I'm out in the field a lot, meeting with people in dental space. I met with Delta Dental last week. What you hear from all of those places is we can't compete in the marketplace with our neighboring states, and we can't compete because we're not investing enough as a state. We got legislation through last year, driven by my office, to raise for primary care the reimbursement for Medicaid to Medicare. So what does that mean? Medicaid, let's say we're just going to pick a procedure. Let's take a physical. Medicare pays the doctor $100 for that physical. Blue Cross United pay $200 for that physical. Same physical, same doctor. Medicaid pays $37. $37 is not a lot of money for that 45 minutes, half an hour that the physician's going to spend. Yeah, they're losing money on that. So we proposed legislation that the General Assembly passed to raise that $37 reimbursement for primary care only to $100. The idea is to drive more money into primary care so that we can attract more primary care doctors to the state.
So I'll give you something else.
Okay. That one wasn't hard enough.
all the insurance, the MCOs, they would much rather put their name on a race car than invest in the system. You look at any of the sporting events, United Health, Blue Cross, everybody's got their name on
Anthem.
on a car or whatever, instead of putting money in the system. My providers, some of them were like 20 years to get a rate increase.
Yeah.
Now, you tell me as a business owner how you can go 20 years without a raise or a rate increase.
Well, that's right.
It doesn't work.
Well, that's the thing.
It doesn't work.
So when my wife is a primary care doctor, and so when we moved here from home, she did her residency at Tufts. When we moved back to Rhode Island, she practiced with 2 other doctors, and they, as primary care doctors, had plenty of patients. They could pay their overhead and make a good living. There are no complaints. Today, she went to Coastal because she had to get bigger. She joined Coastal, which was a group of maybe 100 doctors. And then Coastal needed to grow, and now they're part of Brown. Why? Because the reimbursements aren't enough for the same reasons that Medicare, Medicaid in particular, and commercial haven't gone up enough for them to even exist on their own anymore. That's why you see very few practices now that are on their own. That's not good for healthcare. You want your doctors out of the healthcare system, ideally, not in the system. You want them acting independently. But the reality of the economics of medicine have changed, so that's just not workable any longer.
And then the other thing too, like in my arena with substance use and mental health, it's taken so long to get an appointment, and for those docs to get paid for appointments.
Yeah.
So everyone needs to get in the room. Like the housing crisis that we had back in 2004 when I was involved in that. Everybody was in the room. We locked the door and say, how do we tackle this problem?
Yeah.
And when everybody left, you were a little bit upset, I was a little bit upset, he was a little bit upset. Nobody got exactly what they wanted, but it worked. Till today, still on the books. We're gonna take a quick break. You're watching Recovery TV, and I'm your host, John Tassoni. We'll be right back, my friend, right after this.
And now back to Recovery TV with your host, John J. Tassoni Jr. Recovery TV is made possible by our supporting sponsors and our title sponsor, Kodak. Now, here's John and today's guest.
Welcome back to Recovery TV, and I'm your host, John Tassoni. Peter Neronha is in the house, AG for Rhode Island. Thank you, General, for joining me today.
Thanks for having me.
I want to talk a little bit quickly, because we only got a few minutes left. Any more money coming into Rhode Island? Any more suits?
You know,
on the docket?
I don't think anything that is imminent, but you don't know. I mean, we just recovered $33 million more this year. We finalized Purdue. We picked up another $3 million. Every dollar counts. Just the Narcan alone, we have a decade-long supply of Narcan for the state that we recovered, separate and apart from the money. So there may be a few more recoveries, but I really feel like the money's there. We just have to invest it wisely and keep chipping away at this overdose rate. And if we can bring it down another 25% in another year or two, that's a significant dent.
Yeah, a couple of things. We need more beds, more accessibility, more people to get into treatment, inpatient and outpatient.
Agreed.
Outpatient.
Totally
and
agree.
they need to be spread out
Agreed.
around the state.
Agreed.
Because a lot of people don't have cars. A lot of people use the mass transit to get to where they need to be. South County, I'm always working to try to help South County. They don't have much down there.
Spread out.
Yeah, Rhode Island, Northern Rhode Island too, Burrillville, Smithfield.
Yeah,
We've had some issues over there, but I have to personally thank you for, in your office, to get the money into Rhode Island.
Great team.
To get it spread out and to get it utilized to where it makes a difference.
We're doing our best, and I have a great team back there.
It's really hard to do that, but I got to give you kudos.
Thank you.
There's a lot of Monday morning quarterbacks are out there. I get it, you get it.
do.
So listen, we're all set with Monday morning quarterbacks. We're going to the playoffs.
Exactly.
So, but thank you for all you do, and I really appreciate your friendship.
Thanks for having me.
So folks, next week I have John Cipolla and Ernie Adams from Problem Gambling joining us. And also I have Kodak, live, fully integrated healthcare system right after this. So please join us. If you see something, say something. We'll see you next week.